So I'm Dr. Jeff Marksberry. Many of you know me through my voice on the webinar. Questions you have from practitioners, we love it. Keep it coming. You guys are doing some really good work. We have amazing questions come in every day. We are actually covered up. We're busy all the time, so we know you guys are out there doing the same thing, bringing in patients, practitioners, and spreading the word. So we appreciate it. So I did have one comment on this already. Ray, thanks for mentioning that. I wish I could take credit for the term electroceutical. I can't. I actually stole it from the documentary that we have coming out. But I suggest using that term. I think it's fantastic. Electroceutical falls in line with pharmaceutical, nutraceutical, so it really seems to validate I like the term, it validates our category for electrical medicine. So I'm going to talk about CES, how to use the device, some different protocols, try to do something a little different than you guys normally hear me talk about, but I will go through the basics too because we do have a lot of new people in the crowd also. So first thing we want to talk about is how to use a device, how the device works. Also, Scott got into licensed healthcare practitioners, so he covered a lot of that, but I do want to kind of touch on that again. I want it to come from our general counsel also, but I wanted to cover it. So these are the questions we get asked a lot about: who can treat, who can't, who can write for it, who can't write for it, who can do an order, do they need an order or prescription. So this is a sort of a general list. It doesn't cover everybody, but we do have a lot of one-offs, right? So just like in Texas, we know that an LPC can't order for a patient, okay? If they're an LMFT, if they're marriage family therapist, or they have an addiction credential on top of that, then usually they're okay. So the easiest thing, and what I really recommend, is if you go to Google, right, and you Google scope of practice for whatever practitioner you're talking about, okay? If it's a nurse practitioner in your state, you can Google nurse practitioner scope of practice for Nevada, right? And you can go and see. And the good thing is, as long as it doesn't say they can't use electrical modalities, then they're okay. If there's specific language in it that says this practitioner or this field does not use electrical modalities, that's when you want to say, okay, that practitioner needs to work with someone else in their office. If they have a psychologist in their office or an MD, then they can work with that one, and their license will cover their ordering or getting it for patients, okay? So has anyone not had a CES treatment here? Oh, everybody. Okay, great. So you know the basics, but I wanted to walk through this because you will get questions about this, and you'll get people that have issues with different things. So just briefly, wetting the electrodes, right? We have our felts. If you have your own device, you only need to change those about every week or two, or less than that. It doesn't really matter. You do want to change it occasionally. It does, those are on there for a reason, but with patients, you do want to encourage them to change between every treatment, right? So they'll peel those off, put a new set on. The big concern for a lot of people is buying the solution. Do I have to buy your guys' solution? Okay. We had a really good example of, it was, I think, some Marines that were using this in the field in Afghanistan, couldn't get any more solutions, so they started using contact solution. And we didn't know that, but they actually said, this device isn't working for us anymore. So they sent it back into the office for us to QA the device, and they sent it in with the bottle of contact solution that they were using. So we said, let's just change that out. The device is working okay. Once we changed that out, they did continue to get results. So it was actually the solution that they were using. Okay, so that's the best example I can give you. Now, if someone is out, contact solution may be the next best thing. If they call in and they ask Sherry, she can give them sort of a salt water solution recipe to use in temporary, short term, but we do really encourage them to buy the alpha stem conducting solution. One of the things you'll hear me say on the webinar is that it's designed for a low current, right? So everything we talk about, people want to replace the trodes with their own 10 trodes that they use. This is designed for a low current. It's designed specifically for our device. So we really encourage them to purchase that large bottle. That'll last them a year and they'll be set. Earlobe, if they don't have an earlobe, they can put this other places, right? We can put it on the top of the ear. We had a burn patient at Walter Reed. I talked to their doctor maybe just a month ago who has no ears whatsoever. So the other solution there is they can put the trodes on the trapezius muscle, right? So we'll get into some of that. When you feel dizzy, you get it away from the ears with the trodes. We see that with some brain injury clinics we work with as well. They're dizzy all the time. So when you put the ear clips on them, they get dizzy right away. And the next best thing is to put the trodes on their traps or even on their deltoids or shoulders, and that will get it further away from that cranial nerve that causes the imbalance, and they can do that. So there are some other solutions. Most people are going to be okay with earlobes. Take out your earring if you have an earring on. It's not going to cause any issues or spark or arc or anything like that. It's just that it's easy to put it on the load. All right, so we'll just take the ear rings off. So this is your device. This is the aid. You guys know the specifics about that, so I don't have to get into that. Set your times. So for 20 minutes, obviously you guys know we don't encourage people to treat for a brief period, right? 1 minute, 2 minutes. When we do our shows, people want to try it out just to see what it feels like. You can get an incomplete treatment. If you get an incomplete treatment, you can leave feeling heavy, sluggish, groggy. I can tell you between Sherry and I, the clinical calls that we get when someone calls in who's feels foggy, has a headache, 90% of the time they will not have done a complete treatment. And it's usually the practitioner. So then it goes to practitioner education. Are we doing a good job educating them? Are you guys doing a good job educating them? Because they will many times have their own idea of what they should do. Sometimes that includes changing the frequency, unfortunately. Sometimes that includes a 5-minute or a 10-minute treatment. Do 10 minutes in the morning and 10 minutes at night. We hear that. So they won't be getting a complete treatment. And if that happens, they can feel foggy or groggy, kind of get a headache, things like that. So really encourage them to complete that treatment. Tanya has a really great question that she asked, which is, do you feel as good or better than when you started, right? If they feel the same, then that's positive. We consider that a win because they may feel really good later on, right? So that's a win. If they feel better, that's a win. If they feel anything else, if they feel sleepy, and then they may feel like they could go to sleep. They may look very relaxed and say, man, I could go take a nap, right? I could get a couple hours of sleep. That's okay. If they feel weird, they feel fuzzy, they feel groggy, just put them on for another 5 or 10 minutes. And usually they will be able to tell you when that goes away. And you can usually see it on their face also. So how this works, right? So we go to our famous pictures here. The big thing in medicine is everybody talks about drugs, and that's what your practitioners you're talking to are used to talking about, right? They know how everything works. They think they do. They know how every drug works and where it acts and the side effects. So this is a big mystery to them, especially when you're presenting it for the first time. So you want to speak confidently about it, right? You want to speak quickly and get through this part. You guys want to know every intimate detail about every part of the device, and you do know those things. And in many cases, that's good when you're talking to physical therapists. They're the ones that are going to ask you the characteristics of the waveform and where this works and why does it work that way, and tell me about this channel or this receptor. So electrochemical in nature, the body, typically in medicine, like I said, we talk about the chemical component. The big takeaway here is that only 2% of your nervous system is chemical. So it really is an electrical dominated system. So we play on that. When we talk about our cell receptors, we have our picture here. You guys have all seen this if you've sat through the webinar, right? But something has a contact with that receptor, something has to activate that receptor. And we've always thought, and we were always taught in biology initially and in medical school too, that it's a physical reaction, right? You have to have something come into contact with that receptor to activate it. And once a receptor is activated, that's it. It does what it's programmed to do, okay? And that physical fit is called the lock and key theory, right? And our old analogy is how you open your car door. And 20 years ago, you opened it with a key, and now you open it with a fob, right? It's still very specific, but it's a different model, different type. And that's the one we're talking about now. So with that frequency, we can activate that receptors and many receptors, whatever it's in proximity to. So it's a very efficient model. And that theory, or the theory of frequency modulation, gets us to our mechanism of action and our waveform. Okay? So this is really what we tout with the alpha stem. It's patented waveform. So the thing you want to get across to your practitioner is that they won't see this with any other device. Okay? No other CES device, no other TENS device is going to have this waveform. Okay? The important thing about the waveform is it's patented, and since we've been on the market since 1981, we do have a lot of research, a lot of safety data, so we know what to expect with the waveform. We know the results we're going to get. All right? We know it's going to be effective for 80 to 90% of people that use the device correctly and consistently, and you won't see that with other devices. Right? So another thing we say is it's like a white pill. Right? You wouldn't just say a white pill and take it because you don't know what it is. So every white pill is different, and every device is different. And the real characteristic that sets a device apart is the waveform. Okay? So the good comparison for a TENS unit, if you look at their waveform, and you can Google that and see them, they're just usually a flat line with a square or a triangle, so they're just interrupting that signal you have for pain. And people accommodate to that simple signal over time. So that's one of the big characteristics that sets us apart from a TENS device. A is it's much stronger, 200 times stronger at least, sometimes much more than that. But it's a very simple waveform that your body will accommodate to over time. Okay? Alpha Sim's complex waveform, it's got variability in it, so you don't accommodate to it. And we get calls from people that have literally used the device since the 2000, that may even doctors that still have the 2000. So you can use that for many years and still get benefit from it, and you don't see that accommodation. So a couple aspects that I pointed at here, the spike, it's important to point that out because people will feel that spike. Obviously, when they use a device, they'll feel that pulse, that prickly sensation on their earlobe. Because our current is so low, and that's another important part too, when you turn on the device with a patient or a practitioner, you can tell them it's such a low current you probably won't feel anything. All right? That's how safe, innocuous the device is, that you probably won't even feel anything. But once they do feel the spike, then the rest of the waveform will go into the brain. It'll penetrate the skin into the brain, and we can see with imaging changes. I'll show you in a minute. But there is an immediate effect with that. So the plateau there, that's our envelope. That's where all the frequencies are delivered. Certain frequencies can do different things, and no one's done specific research to say that this frequency is great for depression or this one's for pain. So we use a shotgun approach. We have a range of frequencies. The waveform is 0.5 hertz, but it is a range also. Okay? And there are devices on the market you may hear from practitioners that use a frequency-specific device. Doug and I actually, we talked to the guy that's at Cleveland Clinic that works in the pediatric center there, and he uses a frequency-specific device. He had used it for 2 years and still really didn't know how to use it because it's all trial and error. No one knows that, okay, this one's going to be great for our ADD patients. So it's essentially they try every frequency and different protocol until they kind of narrow something down, and then you got your next patient who's completely different. So it's a huge trial and error thing. With our device, we're hitting those frequencies, and that's why we see so many different reactions from people, so many different things that we can treat. Right? So that's our waveform. Right, so make sure you have 20 minutes. Describe what's going on. So you're going to feel the small pulse. This is so if you want to be a prognosticator, you want to tell them the future. I think this is a really good approach when you're treating someone for the first time. So you're putting the ear clips on. You probably won't feel anything to start, and they probably won't. As you turn it up, you're going to start to feel a small pulse on your earlobe. They will, and then you're going to say at some point you're going to get some dizziness, and so you go up till they get dizzy. So you've already told them what's going to happen several times, and it happened, right? So then you suggest that you're going to feel relaxed next. So naturally, you've already told them what's going to happen a few times, so they're going to believe you, and maybe through power of suggestion, they'll feel relaxed right away. But the device is going to kick in. They will feel the dizziness. The dizziness is important because that convinces them that there is something powerful happening, right? They may not have felt it at first, but now they're dizzy, and so we are working on the brain. Something's definitely going on. So even though you get to that point and come back down, it is an important step for them to see. So I wanted to get into a little bit of cranial nerves here. So there are 12 cranial nerves. If you've learned those, there's a great mnemonic you can learn, and you can pick up all those. I won't repeat that here. That is not a PG mnemonic, but it is out there. So a couple of the things that we actually work on, the big one is the 8th cranial nerve, and we talk about that. We have you guys talk about that, right? The 8th cranial nerve handles hearing and balance. And as you stimulate that nerve enough through the ear clips, you feel dizzy. So that's what we're working on. That's a normal function of that nerve. Okay? It is not a side effect. It's not negative in any way. It is actually a sign that, yes, your nerve works correctly. Okay? So we have that. There are 2 others. There's the optic nerve. Has anyone ever put the probes around their temples and seen little flashes of light? Okay? That's actually a way you can test the probes to make sure it's functioning correctly. You can put those just right across your temple. Your optic nerve picks that up, and you'll see little tiny flashes of light. Okay? Again, not negative. It's just a function of the optic nerve. It turns that into light, and so you actually can see it. Okay? And then the facial nerve, if you treat across your mouth, your tongue, and some people can feel this with CES. We have some people that wear CES and actually see the flashes of light too. It's a very small percentage. They're kind of an outlier, but you'll see that. But with the facial nerve, you can actually get a metallic taste. Okay? So if you put current across your tongue, your mouth, your jaw, dentists that are treating across, you can actually get a metallic taste. Kind of tastes like you lick a battery if you ever did that as a kid. I didn't do that, but people have told me that's what it's like. Okay? So a very distinctive metallic taste. It does not have anything to do with their dental work. It's not negative in any way. This actually used to be in the early 1900s, this is the way that neurologists could check to make sure there was function in that nerve. So it is an actual nerve function test. So during the treatment, so for the current, David, again, your question, as you know, 2 or more, 20 minutes, below 2, 60 minutes. Ask them how they're doing when they're done. If they're relaxed, they feel good, then they're done. Right? If they still feel groggy, fuzzy, anything like that, leave them on for a few more minutes and let them treat through that. And usually they'll feel very good once they get through that. All right, so this is how they should feel. So ignore that word, Jack. We do not say stress. Yeah. So those are what you're going to typically hear. That's the heavy side, right? I've had people say they feel sedated, sluggish, groggy. It's a small portion of patients that experience that. It's usually the first treatment, and it's usually within the first few, 5 to 10 minutes of that treatment. So when we feel that, the key is to let them know that's great. When this is over, you're going to feel amazing. And they will. They usually have a very, very positive response once they finish that. They'll get through that sluggish feeling and they'll feel very relaxed, refreshed. We had one practitioner that said he felt like he'd shaken all the rust off of his brain and his body. So a very positive response, okay? Key for them, obviously finish the treatment. There's our question, do you feel as good or better than when you started? And then they're back to feeling light and relaxed. And they'll be your best patient. That's a positive response. And that's a good way to track. If they feel heavy and sluggish, they're usually going to feel great when they finish. Okay? So what happens if they don't feel anything? Right? So they felt the pulse, they got the dizziness, but they didn't have any difference that they noticed when they got finished. So there's a few reasons for that. It can be delayed response, right? And we know, especially for someone with depression, it's going to take several weeks of treatment before they really see significant changes. Okay? May take several weeks to improve. We have delayed response even that same day or the next day. People come back to us and say they slept great last night or they were more relaxed the rest of the day, so they can come back to you even in the short term and say, I didn't feel anything right away, but I slept fantastic last night. So we see that. And then we know from most of our research, survey data, it works for around 80 to 90% of patients. So you will have patients that it won't work for, right? So we don't want to say that we work for everything for everybody because we don't, and nothing does. And so that's part of it too. We want to say that most people have a response. Here's what we expect, and give them realistic expectations. Okay. So what if the patient feels dizzy right away? So I talked a little bit about this already. But here's our diagram. So that's the trapezius muscle. Tanya and I had a Marine, and she had been in 5 IED blasts in her time as she was deployed. Dizzy all the time. She had constant migraines. So right away with ear clips, it was too dizzy. We actually did this method, and she was still too dizzy, so we moved it out to her lateral shoulder and then finally down to, I think, maybe like her bicep before the dizziness went away. But she had a fantastic response. She wore that for, I think, around 90 minutes to get rid of her headache, and she was very positive after that. So just have to get away from the midline, away from that nerve, especially if they have a significant history of dizziness. So the Astrodes work great for that. They can put those on and still have a CES effect. So what if it doesn't work with that patient? Some things we can look at. Number one is check the frequency, right? They'll change it to 100 hertz on their own. Inadvertently, the doctor may think 100 hertz is better. Let them know that that's not ideal. We do want to treat at 0.5 hertz. We get devices back all the time, and someone got a 60-day loan and said, this didn't work for us. We can look at the cumulative timer, and it's on 3 minutes. So, it's not going to work. Or they didn't take it out of the box. So we see that occasionally, and that's a big explanation of to why it did not work. Even that goes to what you were talking about too with certain meds. Sherry and I deal with that quite a bit when someone calls in and says, it's been 2 weeks, it's not working for me. Have to encourage them to be patient, and we do ask them if you're on medications, especially some different sleep meds. Klonopin is one that if someone's like, I've been using this for a month and it's not working, you can almost ask them if they're taking Klonopin, and half the time we'll get a yes. So there are certain drugs and indications. Depression takes longer to treat also. So we know if they're really heavily medicated, it doesn't mean they won't respond in a week, but we can expect sometimes it may take 4 to 6 weeks before they really see significant changes. So this is one of the survey that we did. This is in the Army Medical Department Journal, so I think most of you guys have seen this. This is in some of our literature as well. But we did civilian responses, 1,750 civilian responses, and 150 service member responses to this. And you can see the colors correspond there, so the blue bars are our service members. And the question in our survey, and you've seen the survey if you've had a device, we used to have the card, now we go online to do our warranty registration. Encourage your practitioners and your patients to go online and fill out their survey because we do keep that and we tabulate that data. We publish it. We do it as part of our post-marketing requirements as well, as Scott talked about earlier. So you can see the service member responses. The question was, if you're treating anxiety, did you find it effective for your treatment? Okay. Overwhelmingly, 90% of the patients, military, and then 85% of the civilian patients said yes, they did find it effective. So we went to WebMD, pulled out their numbers for drug surveys and compared the two, and you can see very comparable to the medications in most cases. Insomnia drugs have a terrible rating, so we did quite a bit better than those drugs. This is the 5th survey I think we've done like this, 4th or 5th, and you can always see right around the 80 to 90% mark for AlphaStim. So we do very well in these. Lower with service member pain. The theory there being that the patients that we deal with are more difficult to treat. Right? You guys that work in the VA or the DoD with us, you see the patients that we deal with that have burns, the IED blasts, things like that, brain injury. So those patients are more difficult to treat than your average civilian patient going in who's complaining of, a bum knee from playing pickup basketball or something like that. Okay, so more difficult to treat. This is survey data, still very valuable. And I mentioned we've done several surveys. So this goes back, you can see 2001 we did a civilian survey, 2011 we did the service member, and then 2013 we did a combination service member and civilian as well. So this just kind of compares the three so you can look at the results. Again, very consistent. So we have the light blue on the left here. These are patients that improved from 25 to 49%, so still a significant improvement, right? And then the dark blue are patients that improved over 50%. Over 50% is considered the highest category of improvement. That's the gold standard, okay, for medical literature. So if we look at anxiety, you can see 67% of the people achieve that mark, so that's huge. There's very few medications that will even come close to that, especially without the side effects. Okay, so you can go down the list here, you can kind of see that. And then the totals are over here. So what we would say in medical literature is significant is anything over 25% improvement is significant. So that would be these two, right, added together, gives you the total of significant improvement. So for PTSD, we're talking about 62% in one survey and then nearly 90% in the other survey. So those are huge numbers when we add that together and get who's actually significantly responding to the treatment. So I tend to focus on one bar first, if you've probably seen this. So the first bar I point out here is depression in the blue bar. Okay? So the blue bars represent patients that were diagnosed with depression, they were taking antidepressant medication, and then they added AlphaStim to their protocol. So this was an addition. And then they self-reported how much they improved. And on average, they reported that they improved 53%. Right? So that's fantastic. Pain was the lowest at 42%. You see anxiety was the highest at 64%. So it was a very good adjunct to the medications they were already taking. Okay? The red bar is higher, 62%. Okay? And these are also patients diagnosed with depression, but they were not taking medications for some reason. Right? Maybe they were newly diagnosed. Maybe they don't want to take a medication. We deal a lot with addiction clinics. Dr. Earthman's going to talk about that briefly in a few minutes. But those patients don't want to add a medication, right? They're avoidant to that. So in that case, they can use AlphaStim alone, and they actually did better, 62% average improvement when they used AlphaStim by itself. And you can see every category. This is not a mistake. It was 100% of the patients had improvement using AlphaStim alone for their headaches. But in every category, we did better. Right? They can also, blue bars, right? They can add it to their medication, and they'll do very well. The other one is we work a lot with integrated clinics. Practitioners that use CBT or EMDR or meditation, hypnosis, things like that, acupuncture. And those fit in really well with this as well. So especially if they want their practitioner or their patient relaxed when they do those other modalities, if they want them relaxed when they go into their group session or their CBT or their physical therapy session, if they want them relaxed, they can use AlphaStim CES prior to that. They'll be more relaxed and they get a better overall result, a synergistic response. Right? 1 + 1 is 3 in that case. Okay? So that's a great graph for that. So if we get into how the device works, some mechanistic slides here. Everybody's seen this, or you should have seen this. This is in our literature overview. Right? So analgesic effect, Dr. Kirsch is going to cover that. So the EEG results, we see an increase in alpha waves, AlphaStim, right? So that coincides. Alpha waves are associated with relaxation. You feel very calm, relaxed, that deep relaxation. As you increase alpha, you also decrease delta waves, and delta are associated with sleep. So as you decrease that, you tend to feel more alert, awake, more focused after the treatment. So that's beneficial also, right? especially for our military members. They can't take, and a lot of professions, they can't take sleep meds, right? They can't take meds that will dull their senses. So AlphaStim is something they can still use, still be very focused afterwards, and they can get by with using that and not have to depend on that medication. Okay. Decreased arousal, agitation. We have some ERs that have used this in the past for patients come in who's agitated, hyper-aroused, anxious, and they can put the ear clips on them in that acute setting just to help relax and calm them down. And neurochemically, we know increase in endorphin, serotonin. We've seen some suggestions of cortisol decrease over time as well, so your stress hormone. So I've got a better graph on that in a few minutes. So that picture comes from several different drawings. Everybody has seen this also, right? I did hear back from a practitioner that we work with at Walter Reed. He's doing essentially this study again. So we'll have hopefully a new version of this. Maybe, she actually said they're finishing writing that up. I got an email from them Thursday. So we expect to see that this year. So another EEG study where patients use a device. They did an EEG pre and post AlphaStim treatment. So we'll see those changes in brainwave patterns. But again, in this case, red is increase, blue is decrease. So we do see the increase in alpha waves, the decrease in delta waves. This is a big one that you need to be able to explain to your practitioners when you show them how this device works, right? So we depend on this picture. Another couple slides from that study. This was Loretta imaging, so a different imaging technique. But this is at 0.5 hertz, but this is at 8 hertz. So this is an alpha, this is alpha range, right? So this is where we want to see activity. And red just shows where the brain was active or more active than the baseline, right? So at 8 hertz, alpha wave, brain's very active, and this is just from that one CES treatment. So almost the entire brain is activated or showing increased activity at that point. When we compare that to delta range, we mentioned that goes down, so you see very little activity. Red was an increase, and blue is decrease, so it's either neutral or actually decreased in some areas too. fMRI study, we have 2 fMRI studies, one with CES and anxiety, the other was with CES and fibromyalgia, and you're going to see that one a little bit later with pain. But what they did here is they took patients who had generalized anxiety disorder. This was done at UCLA. They hooked these patients up to an fMRI. They do the fMRI, see the brain, do 20 minutes of AlphaStim, and then do another fMRI, compared the two. They lit up the areas of the brain that showed change in activity, and what the researchers concluded, the important part, the takeaway, is there was cortical deactivation. So cortical deactivation is great for anxiety, right? And that's the main condition they were looking at. So successful study done at a very good university by their mental health facility there. So mechanistic changes, this is not just AlphaStim, we go way back here, you can see in the 60s. So this just kind of overall covers what can happen with electromedicine in the brain, right? So mechanistically, we talk about neurotransmitter release. We also see an increase, and the interesting thing is you also see resynthesis. So you're releasing what you have, but it's also increasing production as well. So that's an interesting mechanistic side of things. If we look at inhibitory processes, GABA, MA, I'll let you guys kind of read through this, but serotonin increase. The big one we talk about is serotonin because that coincides with depression. Endorphins coincide with anxiety, with depression also. So those are 2 things practitioners hear, that's kind of a buzzword that we can use too. Cortical deactivation, that's the one I just showed you, I mentioned. The other fMRI study, that's on pain, but you see decreasing pain processing in the brain. So amazing for pain. So that's sort of an overall look what's going on here. So we get to safety considerations and primary contraindications. There are no age restrictions. So we have patients that use this, pediatricians that use it on children as young as 2 years old. As long as they are comfortable, you can use it at the lowest level when they're smaller, so they may use it at a lower current, but it is safe to use it with pediatric or geriatric populations. Probably not. What we see with AlphaStim is it normalizes. So if you have someone who already is on an SSRI, right, so their serotonin may be elevated, adding AlphaStim to that treatment is not going to put them into serotonin syndrome. It's not going to put it to a dangerous level. We also have, one of the questions we've had in the past is someone who's got high alpha already, and if you deal with patients that do neurofeedback, biofeedback, they may have a patient who is already starting at a higher alpha than normal, and they don't want that to increase. So I had a talk with one of the practitioners. He's at a TBI clinic at a military base. He does tons of EEG, very detailed EEG stuff. And he actually has documentation of someone in high alpha who used a device and actually came down to a normal level. So alpha stim tends to normalize things. Instead of pushing it further, it will tend you back to normal. Okay. So contraindications, no age restrictions. The two contraindications we talk about here are implanted devices. So there are some examples of those. The key thing here is that it's a powered device. So it has a power source, it runs all the time. Okay? If they can turn it off, there are some implants, pain stimulators, diabetic stimulators that can be turned off, and they can turn those devices off, use a device for 20 minutes, alpha stim, and then turn their other device on afterwards. And we see that a lot with some of the military installations we work with. They have a lot of patients on stimulators. If they have a device that they can't turn off, for some reason they will always call us and say, can I use this with my pacemaker? The smart thing to do would be call the pacemaker manufacturer and say, can I use alpha stim with this pacemaker? Because we know that nothing's going to happen to the alpha stim, but that's not what they're concerned about, obviously. They're concerned about the one in their body, right? So if they do contact those manufacturers, we will gladly give them the documentation they need. The owner's manual usually has all the information they need to give them a yes or no. I can say in my experience, 90% of the time they will get a yes, it's fine. I've had cardiologists actually put someone on a halter and use alpha stim to see if anything changed. They've done different things. They work with their cardiologists. Many times it's pacemakers. Someone that's used alpha stim for many years, they're getting a pacemaker and they want to continue to use alpha stim. So they will work with those practitioners and they can check and see if they get an okay. If it's hardware, so a stent, for example, a heart valve, even if it's metal, for rods, screws, plates, things like that they get for different orthopedic procedures, those are okay. There's no problem with that. Okay. We had a Marine that we treated at Camp Pendleton that had a metal rib cage, essentially got hit by a truck and everything was replaced with rods. We treated him, no issues. So those are okay. Hearing aids are okay. Prosthetics are okay. Okay. But an implanted device, I did have one patient who had cochlear implants. We called the company, or he called the company, and we gave them the information they needed, and they recommended he did not use alpha stim. Okay. So there are those instances. With metal in the body, if it's surgical metal, we know the origin, we know what it is, and that is safe. Occasionally, we've had maybe one or two veterans that had a lot of shrapnel actually in their face or their head. In that case, that metal, because it's we don't know the origin, it can actually be very conductive metal. So those metals can actually heat up. We never had any issues or problems, but if they feel a different sensation, if they feel a warming sensation, we would discontinue treatment, right? Usually if they can't get an MRI, if they have so much shrapnel that they aren't allowed to get an MRI, that might be one of the patients you would ask about. Okay? Pretty rare, but we do see that occasionally. Pregnancy. We don't have much research with pregnancy to this point. We have a group at Texas A&M, University of Texas right now, who's doing a postpartum depression study. So when they complete that, they want to do a prenatal study, which will be our first well-done prenatal study like that. So that's on the horizon, but still a few years away. So adverse effects, what we can see, we do have a lot of research with this device, as you guys know. The most common side effects that we see with all the treatments are a headache or some skin irritation. The headache is a muscular headache. You relax those muscles in the neck and jaw and you can cause a headache. It's very short-lived. Usually that will go away on its own within 20 to 30 minutes. Skin irritation, same thing, that'll go away after you take the ear clip off. It's just on the lobe where you wear the clip. Right? Occasionally you have someone who has maybe some irritation where they wear the trode. If they wear it, especially at a higher level for longer periods of time, they can get some redness. Usually that will go away on its own also. The ear clip design's changed in the last few years, so there's no more metal touching the skin. When we touch that number even decreased further. We rarely see this anymore, that someone has a reaction with no metal touching the skin. We talked about the current, how to treat as far as the level that you feel, right? So one thing we recommend is that you don't turn it up to the max level and just leave it. And you have patients that want to do this, they want to get the strongest treatment, they'll turn it up, turn it back down to a comfortable level. There's no benefit at treating at 6. Especially if you're uncomfortable, right? That'll just increase your anxiety. So turn that down to a comfortable level. And we talked about feeling heavy. If you feel heavy, keep treating. So that's about all we really deal with. All right. Less than 1% chance of side effect overall. And our placebo pills that we use in medical trials have a 10% chance of side effect, right? And those are serious side effects. It's interesting when we do see a study that really monitors and asks every patient with AlphaStim, did you have a side effect? Usually the sham group will have more trouble than the treatment group. They'll have headaches or different issues, and the treatment group was great. So for research, we do have a lot of research underway, right? You guys ask me about this frequently. One of the things that we have actually started underway is a major depression study that we're actually funding. This will be the first study that we're funding. We're in the process of recruiting patients for that now, so that's underway. And that's to help us get that class 2 indication that we talked about for depression. Right? So we have anxiety, insomnia. This is our plan to get depression in that category as well. We don't do two-way crossovers. In many of the studies you'll see this group of patients got treated, this group of patients did not get treated. After 6 weeks, they will switch those groups, right? And this group no longer gets treated. Well, what we see with AlphaStim is that the results last longer than just the 6 weeks that they use the device. So they can go to a group that does not get treated, but they already got 6 weeks of treatment and they're doing well, and those results are residual. They're going to last a while. So in any study that we've seen where they really insist on doing a two-way crossover, that treatment group, when they go to non-treatment, they're still going to have improvement. They're going to be doing better. So we really don't recommend that. We do have what we recommend with our researchers is that they do an open label once they get done. If they have a sham group and they're doing a placebo trial, right, when they get done, just give everybody a device. Right? It's kind of the nice thing to do. They all get treated. They can take it home. They do what we'll call an open label trial where they'll just use it how and when they want to. And in that case, it gives us a real kind of a snapshot of how it would work real life at home with the patient using it how they want to. So studies, 90 studies done. We have about 27 underway. I think I might have put that on here. I did, yes. Okay, this is our sort of our protocol that we use with research. This is sort of the best protocol for double blinding. So we take these patients, if it's going to be a sham control trial, if they want to test for placebo effect, we loan devices to researchers even though we don't fund it. We do support them in as much as we can to facilitate the process. So they get a device and we'll set them to 100 on the dial, just like David talked about earlier. Right? So it's subsensory for patients. They don't feel anything. They don't actually know if they're getting treatment. The researchers don't know if they're getting treatment either. They have sham devices that look and work exactly the same. So you can't tell those devices apart. Everyone's assigned a device. They wear it for the month or 6 weeks, whatever the trial is for, and then they analyze the data. Right? So they're randomized. They don't know who's getting treatment. And once they're done, they look at the serial numbers and they can see who got treated and tell if there was a placebo effect, if the treatment group improved, and decide how the study concluded. So as far as studies underway, we have several underway. Pain depression with cancer patients, that's our big one in MD Anderson. Unfortunately, the researcher that started this, she actually passed away in the fall. So I did finally get a hold of the next contact who's taking over that study, and they're going to finish that. They expect to finish that this year. We have a really well done multi-site study with the Army with restless leg syndrome. That is expected to finish this year. They're done seeing patients, so they're in the write-up portion of that, hopefully published this year. NHS, that's the National Healthcare Service for the UK. One of the ones we're really proud of, the UK is actually looking at installing AlphaStim in their National Healthcare Service. So they have 27 different mental health care facilities across the UK. When you go in and you complain of anxiety, they have a specific protocol that they use as your approach for treatment. At 2 of those facilities, they have installed AlphaStim, so they're treating patients with AlphaStim. They're looking at, is this device, they agreed when we started that there was enough research to say, yes, it's effective. So that was a big hurdle. But the next hurdle is it cost effective? Is it safe? Do the patients like the treatment? So they're not done yet, but one good sign is that they did turn around and order, I think, 100 devices recently. So that's hopefully a good indicator that the study is going the right way. TBI studies, postpartum depression, I mentioned that. EEG changes, that's at Walter Reed too. So we have some really nice facilities doing studies now. So indicated uses. So if we talk about anxiety first, we talk about acute anxiety, there's neuroimaging changes, there's neurochemical changes, so we know there's an immediate effect, right? So where we see this used is just like, now Scott was using CES before he comes up and does this talk because he gets nervous. Right? He wasn't, but that's a good reason to use it. Right? Public speaking is number one. We do have a lot of athletes that use this. We have a lot of special forces that use this even before they go out on missions. One of the gentlemen we talked to who is an embedded psychologist, all the Apache pilots would come to his tent, his treatment tent, use CES before they would go out on mission. They come back 4 or 5 hours later, use it again to help them come down and sleep when they need to go back to sleep. So it's great in that acute setting. We have dentists that use this, pain practitioners doing injections, things like that, procedures where the patient's awake. It can really reduce that anxiety, make it easier for the patient and practitioner to do those treatments. So for chronic anxiety, and these are considered anxiety conditions, right? We just say anxiety, we don't necessarily say social anxiety disorder or PTSD, but they do fall under that anxiety umbrella. So with anxiety, patients can feel really relaxed and calm right away. That's why we can treat acute anxiety. But if they have a chronic condition, chronic anxiety, or even sleep and depression, it may take them several weeks to see improvement. So the ideal setup for a patient would be to treat every day for 4 to 6 weeks. This is ideal. Okay? Treat every day 4 to 6 weeks, see how they're doing. If they're improving, taper down to every other day. Right? Go for another few weeks, month, see how they're doing. And patients do tend to taper over time. And what we see with the survey data is that 6 months out, patients use a device typically once or twice a week as sort of a maintenance dose to keep those improvements up that they've had. Right? So they do keep treating over time. Some patients discontinue after a while and they do great. Others discontinue and they feel their symptoms come back after a few weeks or months, and so they start treating again, so they can kind of self-regulate how often they use the device. Okay, but that is a longer period of time, right? So what we essentially see, and I mentioned this before, depression takes longer to treat, right? So longer to see results, not longer to treat. So it may be several weeks before they see improvement. If they're heavily medicated, things like benzos, Klonopin, we mentioned, they may take longer to treat also, or longer to see results. Okay, so there are some different outliers there. Comorbidities, obviously, response, we talked about that with medications. So some of the research that we have, this is probably the best study that we have, especially as far as anxiety and comorbid depression or depression are concerned. So this was done at Liberty University. It was a 5-week trial, and they took 107 patients in this. So you have your blue bar represents the group that got actively treated over that 5-week period. The red bar represents your sham group. Okay, so they were in the device, in the treatment, using the device every day, but it was an inactive device, so they actually never got active treatment. Okay, for this study, they used the Hamilton Anxiety Scale, which is the gold standard. That's what we want to see. You can see p-value, very good, so it was a very reproducible study, a good effect size, so we did see really great improvement in these patients. Okay, the goal of the group was to see a 50% improvement. You have to have a hypothesis for your study according to FDA. So what they hypothesized was 50% improvement meant success for a patient. And they saw almost 84% of the patients were able to cut their anxiety scores in half in only 5 weeks. Okay, so very significant response. And one thing you'll notice with the graph here is the red bar did see improvement, so there is some sham improvement in that. This is the only study that I'm aware of that we've worked with where they actually charge the patient to be in the study. Usually it's the other way around. They will pay your gas or $20 to be in a study, which is pretty typical. But they actually charged, I think, $25 to be in the study. So when you assign money to a treatment, they concluded that you could actually see some more placebo response than you normally would because they're expecting things when they pay. Right? So when the study was done, they did give everybody a device also for 6 weeks and let them treat on their own. So everybody did get treatment after that. So this was an anxiety study. They included patients that had generalized anxiety disorder. So you had to have that indication. They also realized that many of these patients, because they have anxiety, also have depression. It's around 60% of patients that have anxiety also have depression. So we have a depression graph that almost looks exactly the same, but I will show you that in a minute. So some PTSD research. We have PTSD research underway, but nothing has ever really been published large scale, so we have a few case studies that we like to show. This is a great example of a veteran who used the device for 28 days. This was his symptom log. The blue line represents how he felt before treatment, and the red line was afterwards. So great response, got to 0 most days. The key symptoms we talk about with PTSD, re-experiencing, right, flashbacks, things like that. Avoiding situations, so they'll become agoraphobic. They won't go to the mall or grocery store anymore because there's too much stimulus there. And then increased arousal. All those were cut down by at least 50%. So great response with those patients. They did 2 patients in this pilot study, and then I think they went back and did another 4 or 6. But one of the big things they saw too is that they had fewer nightmares, awakenings at night too, so it helped their sleep. What we do hear a response is that they have very vivid dreams. So they will report that sometimes, but it's not the nightmares that they're accustomed to with PTSD. So here's a little different study. This is one that we talked about. I think we did this on a distributor call, but this was actually done on patients that had anxiety, okay? And when they used anxiety, or when they were treating anxiety, everyone got paroxetine, right? So that was the medication that they used. So that's the blue bar you see. And those patients did have a significant response after 6 weeks of use, right? So a good reduction in their anxiety. They also had a group, the red bar, with that same medication and alpha-stim combined, right? And you can see there was a much better response with alpha-stim. And overall, that difference is significant as well. So there was a significant reduction compared to just medication alone, right? So a very good graph to show your doctor, if a patient's already on medications, will this affect it? Yes, it will, and in a positive way. So we talked about treating acutely. This is a dental study that we had. This was actually in the office. Patients come in, they're nervous, they get CES, and the dentist actually monitored their anxiety, and the patients actually recorded their own anxiety. So we have two different measurements here, okay, but same group of patients. The solid line, the one that looks really impressive, is the one that got CES, and the dotted line was your sham group. So they wore the device every day during the treatment, but it wasn't active. So they actually reported that their anxiety got worse. So you can see that compared to the treatment group. So dental Mark is one that we work with a lot. We work with some dental sleep conference we're going to go to this year. We have a group of dentists that use it a lot for migraine, TMJ, things like that. But there's a lot of anxiety when you go to the dentist. Almost everyone has that. That's pretty ubiquitous. So you can use that just to reduce that acute anxiety. So for this study, this was done at a psychiatric facility here in Texas, very aggressive patient population. I like this as a sales tool also because it really gets into the administrative side of things, right, with costs when we talk about that. So this facility, it's a locked facility. These patients don't go anywhere. They're a ward of the state many times. So it's a very intense psychiatric facility. So they looked at how many aggressive episodes they had with these patients over a 3-month span. Okay, and in that same span, they saw how many times they had to put them in secluded rooms, how many times they had to restrain them or use medications with this group just to keep them safe and under control. So they added CES to that same treatment group, and they went back and they did another 3 months, and you can see every category reduced by at least 40%. Okay, the big one for them was meds, because they reduced medications 42%. That saved them over $12,000 in that 3 months. They also had about half as many staff injuries in that time. So the staff was safer, patients were safer, and they saved money. So that's the trifecta for any facility like this. With insomnia, we really see a mixed type of result. And if you've been at this any time, you've seen a patient that used the device and said, that's the best I've slept in months and years. That's actually fairly common. The other one is that they may take several weeks to see improvement too, right? So especially again, if they have other indications like depression, if they're taking medications, it may be a few weeks before they see improvement. Okay. Walter Reed did complete a sleep study in 2013. They took patients and they treated them 5 days in a row, and after only 5 treatments, they saw an average of 43 more minutes of sleep a night. They did 5 days, day 1 and day 4. They saw what they called significant or statistical significant improvement. Okay. The big thing in there was 43 minutes overall. And any practitioner you talk to, if you can say, in 5 days your patient can be sleeping 43 more minutes a night, if they have terrible insomnia, that's a huge difference. So another sleep study, this was actually with chronic pain patients or fibromyalgia patients. The pre-study bars here, this is actually how they felt before the study started, or how they slept. So most patients are on the blue bar, which means they don't sleep at all, right? Only about 5% of patients get good restful sleep at night. So again, through our research process, they got randomized and they either got the sham device or they actually got treatment. Now you can see the sham device had very little change, so it's almost the same exact result. But the treatment group did very well. Well, now the majority of these patients is getting moderate sleep at night. And that was only in a 3-week trial, so that's a very quick trial also. So when the 3 weeks was done, they gave everybody a device, let them use it how they wanted to, take it home, and in that case you have a much better response where now the majority of patients is getting good restful sleep. So huge for chronic pain patients. So that's the fibromyalgia group. This is another fibromyalgia study. This was done in 2013, but again, we're looking at sleep. So you have 3 different groups this time. So they did, their orange bar represents the alpha-stim response for sleep. This is 8 weeks, so they had a very good response. Your green bar is your sham group. So they wore the inactive alpha-stim. And this one actually had a third bar, which is usual care. So these are the patients they normally treat and the normal treatment that they go through for sleep and fibromyalgia. So very little change in their sleep patterns. The sham group saw a little improvement, but there was a significant reduction with the treatment group. Okay? The one on the right here is actually fatigue, which is another huge problem for fibromyalgia patients. Again, you see a very good reduction. It was not statistically significant, close, but still a very good response with that. And we have another graph with that for pain, and I think Dr. Kirsch will be showing you that. So with depression, we expect a minimum of 3 weeks. So this is one that if we have a choice with the patient or practitioner, if we're talking to them, this is one we want to try to treat every day or as close to daily as possible. Okay? We do talk about sometimes with anxiety, insomnia, the minimum effective dose is really once a week. And you can tell your doctors that. So they can say, well, I can't see someone every day. Okay, so the minimum effective dose is once a week. If they can see them once a week, they can treat once a week, they can still get a cumulative effect over time. Okay? If they're only seeing them every 2 weeks, every month, they may feel great after the treatment, but it's not going to be a durable, lasting effect that they can hang their hat on as far as the patient getting better. And so what we need is consistent treatment, especially with depression. If we can treat close to daily with depression, they can see very significant results. Obviously, it depends on the medications they're taking, how severe their case is, so there's other factors that come into play. All right, the big thing with depressants is antidepressants and how dangerous they are. So black box warning, we know that there's a suicide risk with any antidepressant, so we don't have that, obviously. So this is Zoloft. You guys have seen this picture. The side effects for that drug, and any drug on the market has a ton of side effects. And our big thing we can tout is less than 1% chance of headache and skin irritation. So the big thing in medicine for any practitioner is do no harm, right? That's what you're taught, your Hippocratic oath, so do no harm. Less than 1% chance of side effect is much better than our loaded down medication. And you have to get that across to them in a friendly way, but still, we definitely outweigh that. So you saw this graph before for anxiety. This is the depression results. Hopefully most of you have already seen this. We've talked about this ad nauseum, but this is the best study that we have. So same results for depression, almost the exact same graphic results. Again, 82% of the patients were able to cut their depression scores in half after only 5 weeks. This is very significant for a psychiatrist or psychologist, right? They're looking for any type of improvement, and if you can offer the chance of cutting someone's anxiety or depression in half, that's a game changer for their practice.